Welcome to an ASRM webinar on telehealth, patient care, male reproductive health, and COVID-19, presented in conjunction with the Society for Male Reproduction and Urology. I am Sarah Ramaya, Curriculum Designer at ASRM. Joining us are panelists Drs. James Smith, Jim Dupree, Mary Simplency, and my colleague, Jessica Goldstein. Before we begin, please note, all attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. Let me introduce our moderator, Dr. James Smith, Associate Professor of Urology and Obstetrics, Gynecology and Reproductive Science and Health Policy, as well as Director of Male Reproductive Health at the University of California, San Francisco. His interests include male fertility preservation, counseling, and treatment, particularly helping men and boys with cancer become fathers following the treatment, as well as evaluation and treatment of male reproductive health problems. Dr. Smith, over to you.
Thank you very much. So welcome, and we're very glad that you could participate today in this webinar. So as you heard, this webinar is entitled Telemedicine, Patient Care and Male Reproductive Health in the area of COVID-19, in this era of COVID-19. So I'm very happy to be able to give this webinar with you, along with Jim Dupree from Michigan, Mary Simplency from University of Southern California, and I'm at UCSF. So just please note that the views expressed here do not necessarily reflect those of ASRM and those of us, the speakers. And disclosures are seen on this slide. And we will not be covering science and laboratory issues in male reproductive health. That will be discussed in an upcoming webinar on June 2nd. So today, our agenda, we're going to discuss the male patient and caring for the male reproductive patient with all of the changes that are facing all of our practices. And we're going to discuss what's the same, what's different, and specifically with respect to handling the challenge of the physical exam virtually, assessing sperm quality, doing a post-vasectomy semen analysis, sperm cryopreservation, as well as details of improving and making more smooth running a telemedicine clinic. And then finally completing with looking to the future. And we should have significant time for questions at the end of this webinar. So with that, I'd like to turn over the webinar to Dr. Jim Dupree from the University of Michigan. Dr. Dupree.
All of you on the phone, this is the voice of Jim Dupree. It's a pleasure to get to have this time with you virtually. And as Dr. Smith just said, we will have plenty of time for questions at the end as well.
This is a basic set of information that we would like to just make sure we're on the same page about it. But COVID-19 is the common name given to the virus that's more formally described as SARS-CoV-2. It's a highly infectious disease. It causes an acute respiratory syndrome. It was first identified in late 2019 in the Wuhan district of China, and first identified by the WHO as a public health emergency in early 2020. And it was declared a pandemic on March 11th of 2020. So COVID-19 is certainly a pandemic that has affected all of us. It's affected us personally. It's affected us professionally. And a tremendous amount has changed. But we thought it would be really important to just spend a minute here discussing first what's the same. So despite our personal lives, our family lives, our professional lives being quite different, there's a lot that has not changed. In particular, I think as we all know from our patients, couples still want to build families. Couples are still going to want and need our help. It remains the case that men contribute about 50% of the cases of infertility, or contribute to about 50% of the cases of infertility. In addition, male infertility evaluations will always identify really important other medical pathology beyond just that's needed for the specific questions or issues of infertility in the couple. Men are still going to need fertility preservation. I think we all have seen in our practices that patients are still going to be diagnosed with cancer even in the midst of a pandemic, so our services will be needed there. And that male infertility remains a really important marker of long-term health, and so we don't want to defer infertility evaluations during these pandemic times for reasons well beyond just the infertility needs themselves. So let's talk now about what's different, and what's different is really going to be the thrust and the focus of our discussions today. And as Dr. Smith mentioned, we'll have plenty of time of questions at the end, and so we do please ask and encourage those of you who are also caring for infertility patients or have questions about them to discuss what has been different in your practices. The things that we want to highlight that are different are that clinics are postponing in-person visits. This was done at the very beginning as a means of improving social distancing, at slowing the spread of COVID-19, minimizing the rising burden on the healthcare system. So in some regions of the country and of the world, some of those restrictions are being lifted, but the postponement of in-person visits remains and likely will be an issue for many months to come. There's certainly a backlog that's been created from that. Directly in response to the postponing of in-person visits is a dramatic increase in the use of telehealth, and Dr. Samplasky will go into details about this during our discussions today. As noted with guidance from the American Society of Reproductive Medicine, there's been a postponement of many, if not most, IUI and IVF cycles. As I mentioned about postponing in-person visits, there's physical distancing that's occurring both in society and in the medical setting. There's a tremendous amount of economic turmoil, and especially for those patients for whom they are paying out of their own pockets for their infertility care. This economic turmoil will likely have a direct impact on their ability to engage with us as their infertility providers. And of course, there's a lot of very personal fear and anxiety, both from the patients, from the staff, from the physicians who are caring for these patients. So as we lay out those framework of what's the same and what's different, we wanted to sort of ground everyone's attention for a minute with 5 hypothetical patients. And the question, of course, that's answered at the bottom of the slide is, what do these patients have in common? A 35-year-old man who's hypogonadal, who's been taking clomiphene, a 32-year-old man with idiopathic azoospermia. What about a 28-year-old man that has a grade 3 varicocele who's considering surgery? You could also imagine a 45-year-old transgender female who has had an orchiectomy for gender dysphoria, and a 19-year-old man with Hodgkin's lymphoma who's seeking fertility preservation for some impending chemotherapy or radiation. So all of these patients continue to need our care, and what's really important and what we think is important to highlight here is that all of these patients can be cared for via telemedicine, even at a time when in-person visits are limited or being postponed. So please keep these patients in mind as we continue to talk through some of the specifics about how to continue to care for our patients in the era of COVID-19. So how do we adapt? Well, we know quite clearly that the physical exam is and remains a very important component of a men's health evaluation. We use the physical exam to do lots of important things, both again related to infertility and related to other broader health issues, including identifying testicular or scrotal tumors. The physical exam is the best way to identify a varicocele, both varicoceles that can cause patients pain-like symptoms or cause infertility problems for them and their partners. The physical exam is the most reliable way to identify the vas deferens and to examine the epididymis. Now, telehealth visits certainly include video cameras, and video cameras you could imagine and likely could be understood to identify certain things, a really large testicular tumor, a grade 3 varicocele, which by definition means it can be visualized. But video cameras are also limited both by quality of the physician and of the patient's cameras and display devices. And so despite some utility of telehealth for the scrotal and physical exam, we do think that there remain some really key limitations, and that it's likely going to be most important to defer a really proper scrotal exam until clinic visits are safe. Scrotal ultrasounds can be done by the radiology department, but certainly if we're trying to encourage physical distancing, that still requires the patient to go out to the medical setting, and there's an ultrasonographer that will also be in proximity to the patient. Digital photographs would be another option to describe the scrotal exam. However, again, it's the opinion of our group that it really, in-person physical exam is still going to be necessary at some point to care for that patient properly. It is possible, though, to try and talk patients through doing their own testicular self-exam. And while we do not expect that patients will become urologists themselves, it could certainly be useful to identify what is would be the most urgent or emergent issue, which would be identifying a testicular tumor. And so what we've provided for you here are 2 links to 2 different videos, the first provided by the Testis Cancer Foundation, and the second provided by the Dana-Farber Cancer Institute. We tried to give you some clues as to when the actual details of the exam starts, but both of these are really short videos. They're very well done. Those of us on the panel today have no direct connection to either of these organizations, but Dr. Samplasky actually gets the credit for finding these off the web. And so if your patients are interested in, if you do not have the option of doing a scrotal ultrasound or of getting the patient into clinic soon, we would suggest you consider talking your patient through a self-exam to make sure that they aren't missing something obvious like a testicular tumor that would require urgent or emergent urologic care. So what about semen analyses? So semen analyses, again, remain a core component of the male fertility evaluation. And the options for semen analysis will be different in different settings, depending on what's available to you in your local environment. The first choice, we believe, is a fresh local semen analysis provided by a CLIA-certified facility. Some facilities at various times in the COVID epidemic may or may not have had to stop doing these fresh local semen analyses. And so a second choice could be, in certain situations, a mail-in semen analysis. These mail-in semen analyses, there's many different ones that are out there. There has been some reasonable concordance with a standard semen analysis in some limited studies. However, it's important to acknowledge that the published data is limited. And that if the patient is azoospermic, there still needs to be fresh local semen analyses provided, in particular for the mail-in semen analysis. Yet another alternative would be home sperm testing kits to provide very basic screening. There are, again, different companies that are creating different home basic testing kits. I think important to acknowledge that it's variable what data points are provided. Some of these are quantitative, some of them are qualitative in terms of what they provide. It's also quite variable in terms of how easy it is for patients to use these home semen testing kits, as well as what's asked of the patient in terms of their own interpretation, and then trying to make sure that the medical literacy of the patient matches the interpretation needs of the test. None of these home sperm testing kits that we're aware of appropriately evaluate morphology, and some provide only basic cutoffs, such as a sperm count number that might look low or normal. Certainly not to the level of fidelity that we're used to in terms of really appropriately counseling and screening patients for infertility evaluations. And so again, it's our ultimate recommendation that an in-person evaluation by a urologist, including a fresh local semen analysis, will be needed at some point, but it certainly is possible to initiate the infertility evaluation for the male partner over telehealth using some of these alternative methods. While post-vasectomy semen analysis is not typically, of course, part of the infertility evaluation, it is certainly something that comes up a lot when we talk about family planning needs for couples that we are taking care of. We thought this was an appropriate time to mention that none of the current home or mail-in tests meet the AUA guidelines for clearance after a vasectomy. And so, again, it's the recommendation of our panel that a formal fresh semen analysis is still required to clear men after having had a vasectomy. So, sperm cryopreservation. So, again, at the beginning of my segment of this discussion, I outlined for you some different example patients that will continue to need our care, and I think that those patients that need sperm cryopreservation remain one of the sort of most critical and time-sensitive patients that we did continue to care for and will continue to care for throughout this pandemic. Sperm cryopreservation is warranted if men are about to undergo gonadotoxic therapy, and certainly many of these same principles apply for female patients as well, but the focus of our talk today is on male fertility preservation and other components of the male workup. That's why we also made a note here about concerns about declining sperm quality over time. Indications for cryopreservation would also include gender affirmation therapy that would start to permanently alter the patient's long-term fertility potential. And then other options like military deployment or other occupations with a high risk of bodily injury. It's our recommendation that sperm cryopreservation should be continued by centers that allow for fresh sampling, but it is, if those choices are not available, then there are certain centers or certain services that are available for mail-in samples as a second choice. So this was the point where I wanted to turn it over to Dr. Semplasky, who will talk us through the telemedicine component of caring for male infertility in the COVID era. Dr. Semplasky?
All right. Well, again, thank you for everybody for joining us. I think what our patients are used to is the traditional waiting room, a physical waiting room, and COVID has forced telemedicine to move forward. And I think the reality is it's probably here to stay, and I think there are some awesome opportunities that come with that. There are a number of companies that have sort of virtual waiting rooms. One of them that is sort of commonly used is Zoom. And so you'll have what's actually like a virtual waiting room. So your sort of template or the patients will be listed and visible to you as the provider. And when you're ready to see them, you click on the link and you sort of bring the patient into the virtual exam room. All of these are password protected. If somebody comes up listed, and sometimes they're like, what'll happen is that their phone is listed and it'll say, Samsung 8, and you just have to be sure and sort of confirm that the person that you're seeing is indeed the person that's listed on the schedule. I think this technology will probably continue to advance, and there are some sort of softwares where the virtual waiting room and the virtual visit actually integrates into the electronic medical record. And so this is, a great opportunity for us to work more efficiently. I'm sure many of us have experienced this, that the first few minutes of every telemedicine visit starts with, can you hear me? Can you see me? What I started reminding patients is that we are all learning new technology with telemedicine. I've certainly learned from my colleagues. One of my colleagues suggested that we have a post-it note, very readily available, that tells patients, turn on your audio. We've all had the experience where the patient's talking, but you can't actually hear them because the telemedicine software defaults to a muted state. So sort of instructing them to turn their audio on and then how to do that. You have to identify the patient. I think in most of the electronic medical record softwares, you have to identify the patient using 2 identifiers. And again, if the waiting room just identifies them as their technology device, you really have to just double check that you're talking to the right person. When you're working from remotely, it's important that the environment that you're working from the patient's perspective, closely simulates what it would be like to be in clinic. So something that's quiet, certainly this can be challenging when everyone is working from home, but as much as possible, find sort of a quiet little area that can be yours, where there's not a lot of traffic, there's not a lot of background noise. One thing that a lot of people have found useful is actually attaching a green screen to the back of your desk chair. These are available online, and depending upon which interface that you use, you can either create many hospitals have backgrounds that will integrate with the telemedicine software, so that instead of getting just a blank background, you can get the background of whatever your home institution is. Similarly, it might be advisable to invest in a higher quality camera. This is particularly important if you're doing exams on the telemedicine platforms. But all these things are just going to sort of create a more seamless visit for you. They're going to sort of start you off on the right foot. The patients are going to be seen and heard. They're going to make the patient and you feel like you are in the clinic, and your goals are the same as if you were in the clinic, not that you're working from home or from wherever your home office is. Scribes can telemedicine too. Many of us have scribes working in our clinics. These are oftentimes medical students, people who are familiar with medical terminology, but who will be taking notes and writing notes while you are interfacing with the patient, acting just as a scribe. So these are a great adjunct to telemedicine. I know several providers who've used Scribes in the telemedicine platform. The scribes are in the background. They're muted, so they're not sort of interfacing with the patients at all, but they're allowing you to direct all of your attention to sort of interfacing with the patient and accomplishing the clinic visit. And then they can help take care of some of the typing and note-taking afterwards. Scribes can do more than notes. They can actually help with summarizing prior results. They can pen orders for you. They can create physician communications for you. So, if this is something available at your institution, certainly telemedicine does not take this as an option. Does not take this option away. I think most people who have access to Scribes and have used Scribes find them to be immensely helpful in terms of the number of patients that can be seen, and sort of using your reproductive knowledge to its fullest without spending as much time doing the administrative things that we may not be as quick at. So Medicare now bills one-to-one for telemedicine as opposed to in-person clinic visits. Certainly you have to be careful in your notes and in the number of topics that you sort of cover with patients. If you're going to bill at a certain level, your note should reflect that. And there are relatively sort of straightforward ways to do that, to sort of keep your documentation supporting what is being billed. There's two great websites by the AMA and the AUA that have provided clear sort of guidelines and help for providers to sort of try and maximize billing while providing the appropriate documentation. Another way that we can work more efficiently, and I do think that at the core of telemedicine is the goal to work more efficiently. So how can you spend as much time sort of talking through a patient's reproductive needs and the least amount of time going through a lot of the background stuff? One option is to have the intake questionnaires, just the questions that you ask every person who you're seeing for a reproductive consult. Have that questionnaire sent to the patient in advance. Have them send it either in an email. It can either be a fillable PDF that can then either automatically populate into the electronic medical record, or as a PDF that your administrative support can either upload to the chart or can integrate into your questionnaire. But I think most of us have experienced that these intake questionnaires can really help to guide your your clinic visit and your telemedicine clinic. And so to have these sort of done at the beginning can be super helpful. Some of the reproductive societies have created templates that are available, and you're welcome to contact one of us if you'd be interested in having a copy of that sent to you. Minimizing no-shows. So as I'm sure many of us have experienced, this is an issue face-to-face, and I think initially with telemedicine, this probably a really big problem. And I think this is where our front lines, the people that answer the phones, the people that check the patients in, where we can really help the patients. Certainly with the stay-at-home orders and coronavirus has certainly sort of ushered telemedicine forward. And what I've told countless patients is that we're all having to learn new tricks. But I think most patients with coaching, they want to keep their care moving forward. They just sometimes need a little bit of help. So how can we sort of minimize the no-shows? How can we actually convert the largest percentage of patients from face-to-face to telemedicine that is safe to do so? And I think our very front lines, the front desk staff, the schedulers, I think reinforcing to them that, hey, this is not as difficult, this is not as scary as it sounds. And having the people that are front lines sort of tell the patients, this may sound sort of like it's very difficult, but it's not. You can still see your doctor. You can do it from home. You can do it without the risk of being exposed to other patients and going into a hospital. And we can keep your reproductive care moving forward. And let me help you do that. You know, it also, I think telemedicine has the great advantage of, I think, minimizing the amount of time that patients wait. So there's, you know, there's many reasons that we can sort of give to patients why converting their visits to telemedicine can be both financially and from a time perspective advantageous, as well as sort of minimizing the amount of exposure to a medical facility. But I think our front lines are really the first place that the patients see and can really sort of get the patients on both enthusiastic for telemedicine and also just help them navigate physically getting onto the telemedicine platform. So, you know, the clinic staff who would otherwise be bringing the patients back, doing their blood pressure, taking their intake questionnaires, because that stuff is not happening in a face-to-face clinic manner, you can have that staff be shifted to telemedicine. So at some clinics, that those staff will contact all of the patients in the morning or the day before, ask them to try getting on the telemedicine platform, be sure that they know that their clinic visit day is not the first time that they're doing that, and that on game day, on the day of their appointment, it is relatively seamless to log on and see their doctor. So the same people who would otherwise be doing that in the clinic can help do that from a telemedicine perspective. You know, I think in general, it's nice to sort of have a close contact with whoever that person is for the day. So, you know, at least for our experience, we'll send them a text in the morning, and so that any issues are sort of caught quickly and you sort of stay on track. These people can also do a lot of things that they do in clinic. So updating the patient's pharmacy, updating their surgical history, their medical history, all the things that just sort of eat up time, but that are necessary because sometimes they are pertinent to the patient's fertility experience. Those are things that can be done by the MAs or LVNs. In the event that you are having trouble getting online or having trouble using the telemedicine platform, or I'm sure we've all had patients that have trouble using the telemedicine platform for whatever reason, there's something called Doximity Dialer. It will actually, you create your account, and you can actually call patients, and it will block your phone number. And actually, when you create your account, you can create a clinic number, so a number that is the same as your clinic. So when to the patient, the incoming phone call will appear to be from your clinic. And you can actually do virtual telephone visits on Doximity Dialer. So, you know, we don't have a proprietary interest in this company, but certainly from a patient experience and sort of moving our reproductive medicine care forward, it's a useful tool when the sort of first option is not available. So in summary, you know, COVID definitely sort of has advanced telemedicine. And I think it's probably changed things for the better. We now have more options to see patients. We can see patients from different geographic locations. Patients don't necessarily have to drive hours and hours to come see us if their issues can be managed face to face. And while there is a learning curve to everything, you know, we have to sort of think, how can we always make this work more efficiently? How can we sort of maximize the usage of our time? And I think it's very important that we continue to keep reproductive care moving forward during these times, because patients want to have babies, and there's ways that we can do this that are more efficient for us and more efficient for the patients. And with that, I turn it over to Dr. Smith.
Great, Dr. Stemplowski, thank you very much. So prior to the COVID-19 crisis, our clinic was one that was doing a fair amount of telemedicine, and we looked at some of our numbers last year, and we noticed some important features, particularly from a productivity standpoint. And so overall, we were able to see about 3 to 5 additional patients per half-day urological clinic. So a typical urologic clinic, I might be able to see 12 patients, something like that, and I could see 15 to 18 patients when I had a telemedicine clinic. And the reasons for that efficiency were essentially just getting up and moving from place to place. I didn't have to do that. It was much more on time, as Dr. Simplasky just said, is that my patient at 2 o'clock, I generally saw that patient at 2 o'clock, and I saw the next one at 2:15. And it wasn't like it was in clinic where I would often, if I were only 15 or 20 minutes behind, I would think that was a pretty good, I was mostly on time. As far as access to care, we saw patients from 29 to 58 counties in California for the 377 patients we looked at, and 5 patients from outside the state. Overwhelmingly, patients were very happy. And as far as Press-Ganey scores, and while I didn't put that on this slide, patients were extremely happy with being able to do telemedicine, not have to come in. When we look more quantitatively at this, the patients overall decreased by about 38,000 miles for this cohort of 380 patients, eliminated almost 1,000 driving hours, and at least for expensive California gas, it saved people a significant amount of money in gas and parking fees. Getting across San Francisco can sometimes take half an hour. So patients, even who lived in San Francisco, were still really very happy to utilize telemedicine. So what do we do now? So as we start to look toward the future, and as we start moving into phases where we're going to be getting closer together, we're also providing essential services. How do we handle some of the issues? Number one, there's continuing care that needs to happen. There are new patients who are coming in, follow-up patients who need to be seen. Because of the shutdown and the shelter in place, there's significant backlog for many of our clinics. How do we accommodate the physical distancing that needs to happen? So in our clinic, we've been trying a new model and experimenting to see how this is going to work for our patients. And essentially in a typical clinic urologic day, there will be stone surgeons, there would be urethroplasty surgeons, fertility specialists, a range of different, in my case, benign urologic practice. And we might have 100 to 130 or 40 patients milling around a pretty narrow waiting room. And we have about maybe 18 waiting rooms. Patients and staff are constantly going back and forth by each other, as well as procedures that are happening. And so we struggle, how can we actually see patients and still maintain 6 feet of distance, even if you wear a mask? And we realized we just couldn't do it the same way. So the idea we've had, and we've been experimenting for the last month or so, 3 weeks, is flipping the clinic. And essentially our clinic is now utilized only for procedures. And we have 3 procedure rooms, and the staff that does procedures, they're entirely focused on one surgeon's practice. So my last day, I had 20 procedures for this one day. And typically I would just embed those procedures throughout my clinic day, and I might do 5 procedures, vasectomies, sperm retrievals, things like that. But in this, I did 20 of these procedures, and from my perspective, every 20 minutes, I was going into another room and doing another procedure, and staff dedicated to each of those rooms was cleaning that room and preparing it. From a patient perspective, the patient was in the waiting room all by themselves. They interfaced with our staff 6 feet apart. Everybody has a mask. They walk in, they directly go to a procedure room. Then once they have their procedure done, they leave by a different exit. So they felt, from patient perspective, it was as if they had the entire place to themselves. For us, it so far has been more efficient. All new patients are getting telemedicine, and we're essentially adding patients to that procedures clinic, patients who need essential physical exams, where I'll add them in between those procedures. Currently, almost all, about 95% of our visits are done by telemedicine, and we're able to accommodate these higher volumes. So given the improvements in patient satisfaction we've seen before, given the requirements for physical distancing, this is an approach that we think has promise, certainly for now and perhaps continuing forward. So looking into the future, I do think that it's likely that telemedicine for a number of reasons is going to be here to stay as part of reproductive patient care. As far as the cost of clinic and our own practice, the patient volume had increased to the point where we were talking about multi-million-dollar remodeling. to expand our procedure rooms. And with this new approach, that's not something that we need to do. We were able to accommodate increasing volume, but still remain in our same footprint. That being said, as all of our systems have likely been torn apart, how can we prepare well for the future to start thinking about things like, can we improve access to our reproductive services? Many places around the country really do have poor access to our services and have to drive very long distances to see us. But by the same token, when we looked at our data a year ago, and we found that generally we were billing about one step below. So instead of a level 4 visit, it'd be a level 3 visit. And that has a very significant impact on your practice. But with these changes, we can bill at the one-to-one level that we would before, as long as you're obtaining, documenting a particular way. Now, some of the challenges, though, is thinking through how really do we do a physical exam? How do we examine for those key things like looking for a varicocele, feeling for vas deferens? That's really critical for surgical planning. Do we do more scrotal ultrasounds? And as Dr. Dupree described earlier, do we teach patients how to do self-exams? And I know I have found that many times now, having patients on video disrobe, and we'll do a physical exam, and I'll walk patients through the physical exam. And then improving the published reports for mail-in laboratory and semen testing, so these can be reliable enough for us to use in a clinical setting. So with that, I would like to open up the session to questions, and as we get ready for questions, I'd like to thank the ASRM for giving us this opportunity to speak to you today. We're very happy to answer any questions and discuss really any issues around patient care that you've been having. And I'd also like to thank Dr. Dupree and Dr. Samplasky for their time and their expertise in this webinar today. So as we get started, we have one question. This question is, I'll direct toward Dr. Samplasky. Dr. Samplasky, do you know whether or not Doximity dialer is HIPAA compliant?
I believe it is. I would double check my answer, but I do believe it is. You know, I really try and route the patients through sort of our telemedicine platform. Doximity dialer is sort of the backup plan when the plan A does not succeed. So this is not sort of my go-to, but you know, when things need to happen and they're not happening, that's sort of the plan B. My impression is it is HIPAA compliant, but I would double check that.
And I have a question for Dr. Dupree. So Dr. Dupree, can you tell us a little bit more about how you're handling the physical exam, and specifically how you think about the physical exam and how that has evolved, changing in your own practice, given how important it is?
Yeah, happy to. Thanks very much. So I'll speak just from a sort of personal perspective of my experience in my clinics. I have found myself not ordering many ultrasounds to try and replace the physical exams for some of the reasons that I mentioned earlier. Mostly a combination of wanting to continue to encourage broad physical distancing in our local community. And to me, a scrotal ultrasound exposes patients to probably as well, maybe not as many, but a good number of other humans in a way that would sort of go against the philosophy and the goals of the physical distancing that our state needed. So I've not used that very much. Instead, I've really decided to use the virtual care visits as one step in what will be a multi-step process with the patient. So I have sort of introduced and framed the video visit as an introduction to me, as an introduction to the man's infertility evaluation. I've described from them right up front that we will need an in-person evaluation to finalize the sort of assessment and the final sets of plans, but that we can do an awful lot over video visits. Many of the tests that we need over the interim are things that might take a small 2-3 weeks, or in some cases even up to 6 weeks to get back. And so I was able to reassure patients that by the time in which our limits in clinic were lifted, that I thought I'd be able to get them in pretty quickly thereafter. And so I think overall, given the course that most patients need for their workups, the lack of a physical exam over video did not seem to really add too much time to their overall workup. But at least from a very personal perspective, I continue to put an awful lot of weight on that physical exam as a final evaluation. I think we all have experienced, varicocele is a great example and very important to many of the men that we care for. I think we've all experienced men that we see in clinic with a clear grade 3 varicocele, and for some maybe unrelated reason end up getting a scrotal ultrasound and it says no varicoceles there. And we have plenty of cases like that, I'm sure, in all of our practices. And so for me, I really do continue to rely and believe on the physical exam as a component of the overall evaluation.
Thank you very much. And this next question is for both of you. I'm going to start with Dr. Semplasky. How have you handled the physical distancing in your own practices? How have you struggled with the different trade-offs to achieve that social distancing in your own practices?
I have shifted as much to telemedicine as I can. Anything that can be handled over telemedicine, I do. I am very careful about sort of no double bookings. This is sort of both at the personal and institutional level. I don't want people just hanging around in the waiting room. And telemedicine, I think, helps with that. People in our waiting rooms, the chairs are spread out. People initially were not allowed to bring a partner with them to clinic. I think most clinics now, people are allowed to bring one person with them, but certainly being mindful of that type of experience. Anything that can be done from without touching the patients, I do. I think I'm very mindful about washing my hands when I go in a patient room and when I leave. I think our patients notice that, and foaming all the time.
Jim, how have you handled things?
Yeah, I think many of the points that Dr. Semplasky outlined, we've followed as well. And to follow up on her very final point there, I think we've made a really concerted effort to try and reassure our patients and our community that it's safe to return to our clinics for care. Understandably, I think there's a lot of anxiety among patients throughout the country about, if it's okay or not for them to come in for a medical service or a medical visit that is ultimately necessary. And so through a lot of different communication channels, we have done that. But I think Dr. Semplasky's point about, reassuring them again in person by washing or foaming your hands in front of them is a really important step. The other thing we've done is we've required all staff and all patients to wear masks when they're in the facility. And I think there's some reasonable logic to suggest that the 6 feet of physical distancing was put in place really as a means of limiting droplet spread. And while wearing a mask, we, I think, have to worry or be a little bit less vigilant about the 6 feet of spread. Nevertheless, we also in our team workrooms have sort of closed down every other workstation. Like Dr. Semplasky said, we've made adjustments to our waiting room, and in fact, we're trying to ask patients to wait in their cars until their visits are actually kind of ready to be seen. And then also trying to really emphasize telemedicine as much as possible.
I just want to make one little, what is one point that has been helpful in my practice is when I'm done seeing a patient, I'll sort of put a plug for telemedicine and say, I think our next visit, if I didn't find anything on exam, our next visit can be done over telemedicine, and just sort of say we're doing the best we can to sort of keep everybody safe. I think patients are getting a lot of different information about COVID, and I think we're still learning a lot, but sort of trying to route them down telemedicine for follow-up appointments. And I think if they know if that comes from their physician who has their best interest at heart, I've had that sort of be effective in terms of keeping clinic for necessary things only.
So on a practical question about dealing with internet slowdowns and lagging questions, something I certainly have dealt with many times. One of the practical things that I'll do when the internet is not working very well is just turning off the video. It's such a hog on many people's bandwidth that I'll either have a patient turn off their video, or I'll turn off my video, both, and we'll just have audio. From a billing standpoint, a question that will come up is whether you can bill for that type of visit, and you can bill for that type of visit as long as there is some degree of video that occurs. So if you get that little bit of pixelated video and then switch it to audio, you can still bill for that as a telemedicine and not a telephone call, which bills a much lower rate. And then another practical question for you both is about how, when you have both in-person and telemedicine clinic, do you merge the two clinics? Do you keep them distinct? And if so, how has that worked?
So we have evolved over time, and we are now trying to keep those clinics distinct. I think that there are some logistical reasons. I mean, Dr. Smith, you had said earlier during your discussion about how you tend to run very on time for your virtual clinics. And I think despite everyone's best efforts, in-person clinics are inevitably never quite as timely. There are just too many other sort of logistical issues involved in an in-person clinic. So as a result, we try and segregate them. I also think that patient expectations are quite different. When a patient is in our clinic with us and we do happen to unfortunately be running behind, they know we will eventually get to them. They are in a room in our clinic. They have not been forgotten. And I think understandably when patients are checked into a video session, they're sitting at home and they're staring at a blank screen or some sort of other waiting item, they are understandably anxious about knowing, did they do it right? Why is their doctor not here right away? So we try and be extraordinarily timely for that reason, and we find that segregating our visits is our most effective way to do that. Dr. Stemplaski, I'd be curious for your experience.
Ours is very similar. You know, I think all of this is a work in progress, but in general, we are trying to do split clinics where telemedicine, either morning or afternoon, and procedures, the other.
And a question again for both of you, in terms of handling backlogs and being able to handle the operating rooms, how are your hospitals allowing for elective procedures and being able to get back in and do the cases that we do from a reproductive urology standpoint?
I think patients are still a little bit nervous. Nobody, I think what a lot of my patients, the sentiment is nobody wants to be the guinea pig, like nobody wants to be the first one. But I've also been really encouraged by patients asking me, well, you're my doctor. Do you think this is safe? What would you do? So there's always the sort of balance between safety and sort of keeping patient care moving forward. Certainly some things are more urgent than others, but our ORs are open. Certainly there are additional safety precautions being taken, sort of longer times between rooms, and sort of every patient gets a COVID screen before they sort of come in. But in terms of backlog, the patients, for my patients, nobody's sort of like, I need my surgery now. People want to sort of do it in a safe manner, whatever that looks like for them.
And yeah, for us, we found as well that, putting safety as the first priority for both patients and staff and providers is really paramount. I'm often reminded of sort of Maslow's hierarchy of needs, and I think if people don't feel safe, they won't be able to, be engaged in higher level executive functioning, and that's both for the staff and the patients. And so all of our preoperative patients do also get a COVID test now before surgery, and have many of the same protocols that Dr. Stemplaski suggested. Our institution went through an exercise where we collectively created basically a medical urgency score that could be used across all different types of disciplines. That medical urgency score was then used to basically collate all the different surgeries that are on our various backlogs and then allocate time to the departments and divisions in proportion to the number and the urgency of their backlog cases. So that's the approach that we've taken, and logistically the way it works is about on a sort of 3 to 4 week notice. Our department is given an allocation of OR time, and then we allocate it internally according to those patients who have the greatest need. I'm happy to say that I'm going to get to do some infertility cases at the end of this week, and so infertility cases are still very important, valued by their providers, valued by the institutions, and certainly valued by the patients. And so I'm happy to say that those patients are still getting cared for now.
Well, and then just as we have a few more minutes left in this session, I would love to hear a little bit more about how you envision your practices going forward and how you imagine whether this is, if there are any silver linings that have come out of this, or anything that you'll take away as we look toward the future a year and a half from now, or however long it is, when we can relax these social distancing rules.
I would say for me, one of the things that has been the biggest silver lining is seeing patients who otherwise would not be able to access our services. I saw a patient from Alaska who said that he literally doesn't, and he said he was not able to access a urologist, more or less a reproductive urologist. It's very rewarding to be able to sort of try and help people who are trying to expand their families and trying to do it in a safe way from remotely. And then just from an efficiency perspective, I think you know, our patients are young, they have jobs, so sort of sitting in the waiting rooms for, you know, spending 45 minutes driving to clinic and then parking and coming in and like waiting for a half hour, you know, the whole process takes maybe 3 hours. And sort of so I think telemedicine, seeing your physician and keeping your care moving forward and updating labs and updating semens and talking with your doctor about your care and making that easier, I think will really sort of help our patients get better care.
And I similarly expect that telemedicine and telehealth will be probably the longest lasting impact and probably one of the best impacts to come from us all going through this pandemic. There were some really big structural barriers that were eliminated on both the federal and the private, even the state level insurance, that were real impediments to broader use of telehealth that have now been addressed. And I certainly hope in my beg and plea to any of you on the call today who happen to have a lever at the state, federal, or at the private is to please keep these looser rules in place. I don't mean loose in a bad way. I mean loose in a very appropriate way for patients, just for the reasons that Dr. Samplasky outlined. And so that's one of the silver linings that I hope will continue. And then I think from an efficiency standpoint, I think this pandemic has really forced us to think about how do we make sure that patients' time is most valued, so that when they come into clinic, how do we make sure that all of their appropriate records are available, that all of their appropriate testing that can be done ahead of time is done, so that when they do have a visit with us, both their time is valued, our time is well used, and we can help advance their care and goals as quickly as possible. So those are two, I think, long-lasting impacts, silver linings, I would hope, from this.
I'd like to thank Dr. Samplasky, Dr. Dupree. Thank you very much for speaking today and sharing your expertise. I'd like to thank the ASRM for giving us this opportunity to discuss with all of you. And please reach out to any of us or through any channels through SMRU. And we are very happy to help with any other questions offline. And thank you very much to everyone.
Thank you to our panelists and our attendees. Thank you for joining us. You will receive a survey by email after this session. Your feedback helps us give you the most relevant content. Your input is appreciated. This session was recorded and will be available on our website in the near future. Please join us on our next webinar scheduled for Thursday, May 28th on SART data entry and Tuesday, June 2nd with SMRU on science, laboratory issues, and male reproductive health. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.